Our second case is a 67-year-old lady presented with a new onset abdominal pain, was referred for further laboratory tests, imaging studies. AFP was found to be elevated at 540. She had multiphasic contrast MRI of the abdomen, which unfortunately showed an 8 centimeter encapsulated mass in the left hepatic lobe, showing hypervascularity on the arterial face and washout in the venous face. She had more staging studies with chest, abdomen, pelvis imaging, which showed no metastatic disease. Based on the imaging, she was diagnosed with unresectable hepatocellular carcinoma. In terms of her underlying liver function, given the portal hypertension, platelet count was 75. She was categorized as Child-Pugh A6 based on a bilirubin of 1.8, albumin a little bit low at 2.9, INR 1.5. Platelets count, we talked about 75,000. She had no encephalopathy or ascites at her presentation. Unresectable disease, she underwent TACE ×2. And follow-up imaging at 1 month, unfortunately, showed a progressive disease with a rising AFP of 720. Based on that and based on the data we discussed, Reflect trial, she was started on lenvatinib, 12 milligram once daily, with stable disease at 3 months. Ultimately, at 9 months, the MRI showed now progression in the liver, a new adrenal lesion, extrahepatic disease, and AFP that went back up to 650.
Well, thank you so much, Farshid. If anything, it's quite fascinating, this case, especially that from the beginning, and I think you delineated, is that, if we understood from you, the tumor was deemed unresectable because of vascular involvement, and ultimately the dissection of the data reflected a Child-Pugh A, despite, on the edge, albumin, not our favorite, Billy was a little bit mildly high, and ultimately got embolized. So now, Riad, for you, embolization that many times, what do you think?
Well, a couple of things. One is, I just wanted to highlight again, so this is a solitary lesion, it's large, and technically BCLCA, right? All solitary tumors are BCLCA, and this is another example of sort of the stage migration concept, where when you can't fit the recommendation at that time, then you migrate to the next treatment, in this case local regional therapy, in this case chemoembolization. So there's always a lot of talk about how many times can you chemoembolize someone, and sort of the narrative of sort of 2 chemoembolizations is really something that sort of has stood the test of time, and I actually think that's reasonable. I think there's some data out there that shows that you sometimes need the second local regional therapy, the second chemoembolization, to augment the first response, and so you don't declare failure until you do it twice. Now, as I mentioned before, however, in the other case, you have to be careful how many times you do that, because different patients will tolerate the number of chemoembolizations differently. And as I mentioned again, this is a multidisciplinary team, so we review the follow-ups in tumor board. So there's no such thing as the patients are just being seen in IR, disappear for 3 months, disappear from hepatology, disappear from oncology. Everybody is reviewed, and we make sure that we follow their liver function test. So in this case, I think 2 chemoembolizations to the left side is very reasonable, and there was some response here. I assume this was after the second chemoembolization, and I think that was following protocol.
Fair enough. Amit, does it nerve you that the kind of setup of the Child-Pugh was not like wow? It was okay, but just on the edge, and the platelet 75. And do you think that it was pushed a little bit more than needed in regard to local therapy?
Yeah, I think that you're right. So this, patient once again technically is Child-Pugh A, so they get an extra point for their albumin. But as you said, the bilirubin's 1.8. I mean, it goes up just slightly, and they get an extra point for that. Albumin's close to the edge. If it goes down a little bit, they get an extra point, and then they're a solid Child B, and you're looking at a completely different story. And I think this goes back to Riad's point. It's not like you just hand off the patient and you do multiple chemoembolizations without reassessment. I think you would do the first chemoembolization. You'd probably get imaging as well as a reassessment of liver function. And if you find that the liver function is starting to decline, that's another avenue of TACE failure. And you may then consider a transition to systemic therapy. So I think close monitoring of response as well as liver function as you go through this process is critical. Now, of course, what we have here is we say that the patient underwent 2 chemoembolizations without a lot of detail of what happened between those 2 chemoembolizations. I assume this patient was being followed in a multidisciplinary setting, and I assume the patient's liver function was stable. I think, devil's always in the detail, and these patients are always different. It's a matter of how selective you can be. It's the type of thing where if you treat selectively with that chemoembolization, you're able to treat the HCC, have very little off-target effects, and the liver function can actually remain stable despite being on the edge.
Would you have thought differently, Farshid? It's your case, but would you have loved to start the systemic therapy any time earlier?
I think we would need a little bit more info. I agreed with Amit on this one. Maybe I think in the future, I would say much more likely when we have more robust data that treating the patients earlier will improve outcomes with more potent systemic treatments. So I think the answer would be in the future probably much more likely than today on this case.
Yeah, actually, if anything, interestingly, for us in the US, we don't have such data, but no doubt that our colleagues in Japan have put themselves a little bit, or delineated for themselves a certain kind of regimen, how many embolization, what's the sequence, what's the time in between embolizations, to make sure that people are not pushed to the edge before they get into systemic therapy. But anyway, in that case here, the patient ultimately, as you already mentioned, get on systemic therapy, get lenvatinib, and we already spoke plenty about lenvatinib. We like very much, as we said, the non-inferiority for sorafenib. We kind of definitely are happy to see that the progression-free survival was almost 3 times higher than sorafenib. We like very much the response rate of 26% by RECIST 1.1 and 41% by modified RECIST. But at the end of the day, despite all this good material, and this is an amazing drug, and people can stay really quite well on it for a long time, but other people are going to progress, same like your patient over here.